want to start?
Well, it is 3 o'clock. Shall we start or we wait?
Sure, let's start.
Okay. So, Bismillah Rahman Rahim. I am Dr. F.M. Kamaluddin, welcoming you all to our virtual academic program. As Dr. Zakir was telling, just for Peter, I am telling that this organization, it was founded by Professor ABMF Karim, who was the emeritus professor in Free University in Amsterdam. And he is our country people. So in 1996, he founded this oncology club with the concept that to break the barrier of this region, that senior and junior should not have a big barrier. So in a club, they can talk and they can chat and they can discuss. And at that time, we started in 1996. And unfortunately, we lost Professor Karim in 2012. And Professor Hai was with him from the beginning. From 2012, Professor Hai is our president. And our objective is always to do only academic activities. We are focusing on manpower development. So we know this is a time of social distancing, but we want to connect with each other in the era of this social distancing. So that's why we have taken this endeavor to do this weekly meeting. And our main focus is actually the junior students and the mid-level doctors. But today we have invited some seniors also. Whoever have time and interest, they can join us. So today we term this program as how should I treat my patients following evidence-based medicine? Unfortunately, the practice of evidence-based medicine is not very much popular still in our country. It is emerging. So for the junior community, we want to make it popularized. That's why we want to organize this session. And today we have Professor Peter Schmid as our overseas faculty, and our local speaker is Dr. Arunangshu. And we have, as usual, 2 foreign guests, overseas guests, is Dr. Mohammad Zakirullah and Dr. Sheikh Farida, SK Farida Ahmed. So first I introduce local speaker, Dr. Arunangshu. He is a young oncologist working as associate consultant in Square Hospital, one of the leading private hospitals in our country. And he will be talking on how should we treat triple-negative breast cancer from current standard to future possibilities. I'm happy to see the growth of this gentleman who started his career 10 years back. Now he developed himself as a faculty. So now I want to introduce Professor Mohammad Zakirullah, who is my senior brother, my senior colleague, maybe not from the same medical school, but from the same college. So we are so happy to see that he's doing a wonderful job in UK. And now he has established himself as a consultant surgeon, taking most interest in breast surgery also. Another person, Dr. SK Farida Ahmed, he is my just 1 year junior colleague in my medical school. And I'm proud of him because this known face of me in medical school is now a renowned breast surgeon in UK. We are so grateful to both of them that from the very beginning, they have been supporting us in all our academic activities. And in this weekly meeting, they are participating every week, sacrificing their holiday. Thanks to both of you. Now I would request Professor Dr. Zakirullah to introduce Professor Peter Schmid, who is our overseas faculty today. Professor Zakirullah.
Thank you very much. Just to correct this, I'm actually still a consultant surgeon, not professor. But anyway, let me introduce you to Professor Peter Schmid. Peter Schmid is a professor of cancer medicine and lead of the Center of Experimental Cancer Medicine at Barts Cancer Institute. He is the clinical director of St. Bartholomew's Breast Cancer Center and honorary consultant medical oncologist at Barts Hospital. He also leads the cancer immunotherapy group at Barts Hospital. Peter studied medicine in Munich and Aberdeen. He was awarded scholarship by the German National Academic Foundation, the German Academic Exchange Service, and Hans Schelt Foundation. He subsequently completed his specialist training in the internal medicine, medical oncology, and hematology in Berlin. He undertook an MD in clinical chemistry at the Technical University of Munich and a PhD in medical oncology at the Freie University in Berlin. Peter moved to the UK in 2005 to take on roles as senior clinical lecturer and director of the Hammersmith Early Clinical Trial Units at Imperial College London, and subsequently as foundation chair in cancer medicine at University of Sussex. He focused his clinical practice on breast cancer, lung cancer, and cancer immunotherapy. He led the formation of cancer immunotherapy group at Barts Hospital, which have become internationally leading in this rapidly developing field. He has an international reputation for cancer immunotherapy and leads a number of global immunotherapy trials. Peter has particular research interest in triple-negative breast cancer and endocrine resistance and has led more than 20 clinical studies and several translation research programs in these areas. His interest lies in personalized cancer medicine utilizing novel biomarkers, for example, from blood samples, and innovative biomarker-driven clinical trial strategies to develop new treatment strategies. He leads an international group of established blood-based circulating biomarker. Peter was awarded the Breast Cancer Research Award 2012 by German patient group Mamazone. He is a member of several national and international cancer organizations and research group and has been involved in international consensus meeting on the management of breast cancer. He is a member of breast cancer faculty of European Society of Medical Oncology and has been chair or member of several medical research communities. He has authored or co-authored more than 150 publications and have been an invited speaker and session chair at major European, North American cancer, and Asian cancer conferences. He has published a book on the management of bone metastasis, 3rd edition. Outside his research areas, Peter has a strong interest in patient-doctor communication. For several years, he ran a program to train oncologists and oncology nurses in communication skills, supported by several patients groups. And not but least, is a very nice gentleman, a very good colleague of mine. So welcome, Professor Peter Schmid.
Thank you very much.
Okay, Kamal, you can take over.
Unmute karo.
Okay.
Thank you, Zakir Bhai. Thank you for the introduction. Now, I would like to request Professor M.A. Hai, who is the president of Oncology Club and also the patron of South SFO, to say a few words and, as per our custom, to start our session. Professor M.A. Hai, sir.
Thank you, Kamal. It's a great occasion for us, Oncology Club, to have Professor Peter Schmid amongst us. My heartfelt thanks to Peter for his kindness, and also for Idan, Zakir, they are our members. We cannot consider him as a foreigner, them. But he's already there, our own members. And young member, our Arunangshu, is going to speak today. Sorry, I'm having some trouble with the throat. Welcome, welcome to all the participants and guests. Hope we shall enjoy these things. And as you have already heard, that our motto is to improve the oncological services in Bangladesh, improving the manpower, and developing the skilled manpower in the field of oncology. And with that goal, we are working in this field. Dr. Director Farid, they know they are working with us very, and Professor Peter possibly will be doing these things. Hopefully, we shall get him in future also. We're interested to learn from him about the patient doctor situation. Okay, I'm sorry, I should start now. I'm already late. Okay, Kamal, start.
Thank you, sir. So we want to start with our local speaker first, then we will ask Professor Peter to talk, and then we will have a question session. So may I request Dr. Arunangshu to start his session. Arunangshu.
Can everybody see my screen?
Yep, we can.
Thank you, Oncology Club, for giving me this opportunity to speak in this eCME. And also thank you to Kamal Bhai for inviting me to speak in this session. Without one or two few introduction, I don't want to start this session. This kind of academic activities, I remember started back 10 years back, 2011. It was my privilege to be a part of that teaching activity started by Kamal Bhai. So now it's honor to be a faculty or a speaker in such presentation after 10 years. So it's my great honor to be in this session. So today my topic is how shall we treat triple negative breast cancer from current standards to future possibilities. Before going into the topic, few introduction about triple negative breast cancer. First of all, a triple negative breast cancer lacks expression of ER, PR, and HER receptor. These are a group of highly aggressive tumors present with rapid growth and more likely to be diagnosed clinically rather than mammographically. TNBC accounts for approximately 15% of the breast cancer diagnosed worldwide. Commonly, it's diagnosed in women who are younger than 40 years of age. So what are the risk factors of TNBC? Very few risk factors have been identified. First of all is that BRCA mutation patients are more likely to have triple negative breast cancer. There are some racial factors like African American and premenopausal status. Obesity and young age of first pregnancy is also another risk factor for TNBC. Today I'll not say detail about the pathology, how it is being diagnosed, but a few molecular classification of TNBC I want to mention. TNBC have been characterized by gene expression profiling to some subcategories. Basal-like subtypes like BL1 and BL2, immunomodulatory subtype, mesenchymal stem-like, and luminal androgen subtypes. So, treatment-related discussion, I'll focus on neoadjuvant, then adjuvant radiotherapy, and systemic therapy in metastatic TNBC. So first of all, the basic about neoadjuvant therapy. When we are going to give neoadjuvant therapy in breast cancer? Just to recap, because we had a session on neoadjuvant therapy 2 weeks back, but still I want to review on these few points. So who are candidates for neoadjuvant therapy? Patients who are upfront inoperable, like inflammatory breast cancer, bulky or matted N2 disease, N3 nodal disease, and T4 disease. Some patients are preferred for neoadjuvant therapy like HER2 positive disease, and most important for today's session is TNBC. A triple negative breast cancer whose node is N1 or more, or T is 2 centimeters around, it is preferred to give neoadjuvant therapy. So what is the benefit of neoadjuvant therapy in triple negative breast cancer? Why we are looking at neoadjuvant in TNBC? The key point behind this is pathological complete response. According to this NCCN recommendation, we can see that if we can achieve pathological complete response or PCR with neoadjuvant chemotherapy, that can reflect in progression-free survival and overall survival in TNBC patients. So patients have chances to survive more as well as have very good response if they have pathological complete response after neoadjuvant chemotherapy. So this is not only playing as a debulking the disease, but also as a very good predictive factor as well. So now I move on to the adjuvant chemotherapy. Again, what are the indication of adjuvant chemotherapy in triple negative breast cancer? Today's area of focus is TNBC. We have discussed about the other triple positive or HER2 positive, but the indication of TNBC chemotherapy adjuvant is, here we can see it is categorized into two broad categories. First of all is those who are node negative, and those who are node positive. So if it is a node positive TNBC, there is no doubt about it. The patient will get adjuvant chemotherapy. So let's come to the first part, node negative subcategory. It has been divided into 3 groups: tumor less than 0.5 centimeter and tumor more than 0.5 centimeter. So tumor more than 0.5 centimeter is considered for adjuvant chemotherapy. But tumor less than 0.5 centimeters can be omitted of chemotherapy, but we need to see the pathological status of the node. If PN1MI is present, then chemotherapy needs to be considered. Why I'm putting this slide is, if we look at the slide closely, there is only one line written here, no adjuvant chemotherapy, a very little area. So most of the guidelines here is recommended to give chemotherapy in adjuvant chemotherapy in triple negative breast cancer. So what are the agents mostly used in triple negative breast cancer? Most of the time in breast cancer, we are using conventional chemotherapy, which is AC 3 weekly. But in triple negative breast cancer, we should consider dose-dense chemotherapy compared to conventional 3 weekly chemotherapy if the patient can tolerate. And in selected group of patients in neoadjuvant setup or also in adjuvant setup, patient need to be considered with carboplatin or platinum agent along with the taxane group of drugs, because we know if the patient is BRCA positive, they are highly susceptible to get response with platinum group of agent. So triple negative breast cancer, when we are choosing an agent, the agents are almost like other breast cancers, but 2 key factors is we have to give it quickly, because breast cancer triple negative is a highly aggressive disease. It proliferates very quickly. So instead of giving 3 weekly chemotherapy, we'll try to give it dose dense every 2 weekly. And in a selected group of patients, when it is indicated, we should add carboplatin to the treatment regime. There are a role of capecitabine as well in early TNBC. What is that role? When we give neoadjuvant chemotherapy in TNBC and we see that we haven't got a very good pathological complete response, means there are residual disease after the chemotherapy. In that case, we should consider this patient for adjuvant capecitabine at least 6 to 8 cycles. So what is new in early TNBC? I'm putting this slide as a teaser. I'll not tell about it. We are very happy and proud that Professor Peter is with us. He's going to tell a detail about it. I'm not mentioning. Okay, those were the areas of neoadjuvant and adjuvant chemotherapy in triple negative breast cancer. What about adjuvant radiotherapy? We know that breast cancer, when we consider for radiotherapy, we categorize into 2 groups. One is the lumpectomy group, other is the chest wall group. So what about the lumpectomy? Who are going to get radiotherapy? This is for a review again. So all lumpectomy patients will get adjuvant radiotherapy. That is a must. But whether we should include the axilla or not, whether we should give the lymphatic area or not, that is the area of consideration. So a lumpectomy patient who have 4 or more axillary lymph node positive will definitely get whole breast radiotherapy with or without boost to tumor bed plus radiation to infraclavicular region, supraclavicular area, internal mammary nodes, and any part of the axilla who are at risk. So this area we will irradiate. But what happens if 1 to 3 nodes are positive? Definitely this patient will also get whole breast radiotherapy with or without boost, plus we should strongly consider for infraclavicular, supraclavicular, internal mammary nodes to irradiate. But if nodes are negative, what should we do? We should give whole breast RT, plus we can consider for nodal irradiation in certain situations. What are those situations? In central or medial tumor, or tumor more than 2 centimeters with other risk factors such as young age, extensive LVI, we can give nodal irradiation. Otherwise, whole breast radiotherapy is good enough. Let's go to the mastectomy group. Mastectomy is also radiation indication is based on nodal status. So if 4 or more lymph nodes are positive, RT is considered as like before. So 1 or 3 nodes, also RT is strongly considered. And other areas are, if nodes are negative, but if we think that our tumor size is more than 5 centimeters, we should consider for radiotherapy. If margins are positive, we should consider for radiotherapy. But if negative axillary nodes and tumor are less than 5 centimeters and margins are adequately clear, that is more than a millimeter, no RT is needed. This is as per NCCN guidelines. I want to say a few things about this area. Whether we should really left alone this group of patients, particularly TNBC, if it is a hormone positive or HER positive disease, we can follow these guidelines. But if it is a triple negative breast cancer, should we give radiation here or not? So this is a controversial question with what I am about to ask. Hope the panel will discuss in detail later. Is RT mandatory in all mastectomy cases? There is a very old Chinese study done back in 2011. A big randomized trial, around 681 patients participated in this trial. This is a trial on triple negative breast cancer patients. They randomized in 2 groups. One is that they irradiated all patients with radiotherapy, other group they haven't. I want to mention this trial is done on early stage breast cancer where mastectomy has been done. So it is a small tumor, margin clear, RT may not be considered as per the guideline. But in this trial, they have given RT to one arm and have not given RT to other arm. So what happened, you can see, if you see the progression-free survival is quite high. We can see a big difference in the patient who received adjuvant radiotherapy in post-mastectomy status. Also, if we look at the overall survival data, we can see still the overall survival is also high. So this study concluded that patient received standard adjuvant chemotherapy plus radiation therapy was more effective than chemotherapy alone in women with triple negative early stage breast cancer after mastectomy. So what about the short course radiotherapy for TNBC? Is it enough? This is another controversial question in TNBC, whether we should go for short course radiotherapy. Short course radiotherapy nowadays has become quite a standard of care in Bangladesh due to our machine load, due to a lot of number of patients. And particularly in pandemic time, when shorter course of treatment are recommended from different institutions, this short course radiotherapy in breast cancer is playing a very significant and good role. We can finish the radiotherapy quickly and early, but can we safely deliver short course radiation in TNBC? Is it safe enough? So there is a article published very recently at the beginning of this year. The title was Effect of Clinical and Treatment Factors on Survival Outcomes of Triple Negative Breast Cancer. This is done in Australia. It was done between 2006 to 2016. 214 patients of TNBC, they have reviewed what was the factor behind overall survival and progression-free survival. My focus is on conventional fractionation, which was 50 gray in 25 fractions, and hypofractionation, which is 40 in 15 they used in Australia. In this study, they have seen that there is no difference in disease-free survival in conventional group versus hypofractionated group, statistically no difference. And also in overall survival, there is no difference in these two groups. So this study concluded that the type of radiotherapy technique and fractionation protocol were not associated with DFS and OS. So This is also another area of discussion and controversy. So now I want to move into the systemic therapy in metastatic TNBC. Before going into the systemic therapy, what about the re-biopsy in metastatic TNBC? A confirmatory biopsy of a suspected lesion should be obtained when possible with reassessment of ER/PR HER2 status. We should not take it for granted that when a TNBC is coming back, it is coming back as a TNBC. It can be a different entity as well. Because there is a possible discordance of these markers between primary and metastatic. And at this time, we should definitely see the PD-L1 status of the disease as well. I'm going quick. So these are the common recommended regime which we can use in second line. So if we have gone through anthracycline, we can go for liposomal doxorubicin. If we have given any of the taxane, we can change. We can go to gemcitabine. There are other agents which work more like vinorelbine and eribulin, and definitely BRCA mutated should get olaparib kind of medication. Platinum also have a very good result in TNBC, as I have already said, and PD-L1 positive patients should receive treatment accordingly. So this trial, the Keynote 355 randomized double-blind phase 3 study with pembrolizumab and chemotherapy versus placebo plus chemotherapy with previously untreated locally recurrent or metastatic TNBC, have shown very good result with pembrolizumab, where there was CPS, which is the PD-L1 positivity is more high, showed a very good result. Again, this trial, I'll not say anything about it. I want to hear it from the trialist. The principal investigator is with us. He will tell in detail on it. So what about the BRCA mutated metastatic TNBC? Inhibitor of or the PARP inhibitor may be particularly useful in TNBC susceptibility gene mutated breast cancer. The Olympiad trial 121 BRCA mutated TNBC metastatic one showed a very good PFS when they were treated with olaparib. So what is new from this? Sacituzumab can also be considered in, it is not available in our country, it's still in the trial phase. So it can also be used in TNBC when all lines of therapy have been failed. So I'm almost end of my presentation. So if I want to conclude, I say TNBC represents a challenge for patients and clinicians due to its poorer prognosis and fewer treatment options, which are reflected with high mortality and recurrence in comparison to other breast cancer subtypes. Immunotherapy may be the game changer in this challenging disease entity. Thank you all.
So thank you, Arunangshu. Now may I request our today's overseas faculty, Professor Peter Schmid, to make his presentation. Peter, over to you.
Peter, please unmute yourself.
Okay. Can everyone hear me now? Is that better?
Yes, we can.
Brilliant.
Yes.
Apologies for that. So triple negative breast cancer is, as we heard, is an aggressive subtype of cancer. But I feel in the last 3 to 5 years, we've really started making a difference. When patients come to me now, they still go online and say, outcome of triple negative breast cancer is disastrous. But actually, we have started turning this around. There are 2 or 3 things I want to share with you today, which give me a lot of hope. And I do think going forward, it won't be the case as it was before, that it was the most difficult to treat subtype. Now, you already heard how we treat triple negative breast cancer in principle. And this is really where we were about 3 years ago. And in many places, there's still primary surgery. I would always encourage to do primary chemotherapy, neoadjuvant chemotherapy. And the reason is, as you heard, is clear. There are two reasons for that. The first is there's a group of patients who does amazingly well and has what we call a path-CR, and those patients have an excellent outlook, 95%, 3-5 years disease-free interval are likely cured. But you have got the second group who have residual invasive cancer, and they unfortunately have a high risk of recurrence with around 50%. What we routinely do now in these patients, we give them after surgery the adjuvant capecitabine chemotherapy, which can reduce the risk of recurrence by about 40%. So again, substantially improve the survival. But we're also looking at new research strategies in that area. When it comes to the metastatic setting, it's very much dependent on how we treat it in the early setting. We increasingly, in the early setting, give anthracyclines, taxanes, and platinum. If patients then have capecitabine, then often you run out of options relatively early in the metastatic setting. But the standard used to be taxanes in patients who are at least a year out of chemotherapy. Platinum obviously play an important role, bevacizumab in some parts of the world. And then depending on how patients were pretreated, often in third-line setting, we run out of options. Now, if we look at metastatic triple-negative breast cancer, and I want you to remember that number, about 2-3 years ago, the median survival was still only around 12, 15, maximum 18 months. And we have started changing this massively. One of the reasons why we struggled to make an impact in triple-negative breast cancer was, as you heard, we looked at it as one disease, and it clearly is not one disease. There are several classifications that look into the different biology and how that drives different subgroups of triple-negative breast cancer. You had one of the classifications. I'm sharing a different classification. They're all very similar. And this classification is very simple. It has 4 subgroups, 2 basal-like groups, one immune activated, one immune suppressed, mesenchymal, and then an AR group. Now, all of these subgroups were helpful initially in making us understand that triple-negative breast cancer is very heterogeneous. For some of those subgroups, we have found targets. But what I feel is going to happen over the next 5 or 10 years, we will get rid of those subgroups again, and we will look at treatment-specific subgroups. And I will explain this in a second. But I think the first subgroup you're aware of is a group of patients who have BRCA mutations. And that's about 10 to 50% of triple-negative patients. There we have seen a clear benefit from PARP inhibitors. There's now data coming out that even in patients who don't have BRCA germline mutations, but possibly tumor mutations, there may be a benefit. And so we will probably widen that indication for PARP inhibitors. There's a second group there, which is called luminal AR, and it's a type of cancer that look like hormone-driven cancers, but are obviously estrogen receptor negative, but instead androgen receptor positive. And we make good progress there with anti-androgens, but that's a small group and behaves very differently to the rest of triple-negative breast cancer. Now, here's where it gets a little bit more difficult. There's a group of drugs coming through called AKT inhibitors, and AKT is a bit like a master switch in those cancer cells. And if it's switched on, then the cancers proliferate more and are more resistant to chemotherapy. And we have done a randomized trial where we show if we add the AKT inhibitor to chemotherapy, patients respond better, longer, and live longer. But the interesting thing is this seems to be dependent on certain mutations, as you can see here, AKT, PI3K, or PIK3CA is the gene, or PTEN. And that goes already across those 4 subtypes. And I'm pretty confident that the phase 3 trials we are running at the moment with AKT inhibitors will be positive, but it will then define a new subset that doesn't fit into the initial classifications. Similar story we have with ADCs, which are just coming through. And you've heard of the first antibody-drug conjugates. So antibody-drug conjugates are an antibody that targets triple-negative breast cancer in this context, and who have a toxin, a very active chemo drug bound to it, like TDM1, go inside the cancer cell, destroy it from the inside. And again, these antibody-drug conjugates, the most developed is sagistumab, which just got approved by the FDA, but there are others coming through which are very promising. they go between those different subgroups you have here, will again define new subsets of triple negative breast cancer. Now, the main reason why we're here today is to talk about immune therapy. And the reason why I shared this classification with you is because you can see an immune activated group and an immune suppressed group. So from an immune point of view, triple negative breast cancer is also different. Some are already very immune active, and others are very immune inactive, and we probably will apply different strategies in the future. Now, if you look at the interaction of cancer and immunity, it's complex. It's not like an AKT or a small molecule inhibitor where we flick a switch. It's a complex interaction, as you see in this cancer immunity cycle, that starts in the bottom left corner where you have the number 1. And it is in order to get the immune system to tackle cancer, we need to release those cancer antigens. And that can happen spontaneously, but it can also happen through effective chemotherapy, through radiotherapy, through anything that destroys cancer cells, releases those antigens. They are then taken up in the antigen-presenting cells, lead to priming and activation in central lymphatic organs. These immune cells then need to go back into the tumor, travel through the blood system there, infiltrate the cancer, recognize the cancer cells, and then can start killing the cancer cells. Now, if we talk about immune therapy, immune checkpoint inhibitors, atezolizumab, pembrolizumab, where do you think they work? They don't work on the whole cycle. They predominantly work here on number 7, where we kill cancer cells. But in order to get the immune system going, we need a combination of drugs to optimize this. Now, this is in a very simplistic way what we need, all you need to know about cancer and immune therapy. On the right side, you see for immune therapy to work, we have to have immune targets. And immune targets are neoantigens. They're antigens, they're proteins that are on the cancer, which are not on the normal cells, because otherwise the immune system would have learned to tolerate them. So where do neoantigens come from? Neoantigens are usually linked with mutations. It's difficult, not impossible, but it's difficult to have a neoantigen without a mutation because you need a new protein sequence. Not every mutation, however, does lead to a neoantigen. The second and third thing we need for immune therapy to work is what you see on the left side of the slide, the active immune system. And that's dependent on 2 main things. One is what I describe here as TILs, tumor-infiltrating lymphocytes, the immune cells in the cancer. But it goes very much beyond just a few lymphocytes. There's about 20, 30 different cell types in the immune system. Some of them are good, some of them are bad. So it comes down to the ratio of the good and the bad cells, and also where are they around the cancer cells in the stroma, how do they interact? That's something we're beginning to understand. The last point is, are those immune cells active or not? There's certain ways the body switches the immune system on or off, and that makes sense. If you have a bacterial infection, you don't want your immune system to fire for the next 30 years. You want it to fire for a week, and then the immune system gets downregulated. And that's why we have activators and then inhibitors, which are the so-called checkpoints. Again, the question to you, where do the immune checkpoint inhibitors work? They literally work here on the red bit, where we say checkpoint inhibitors. But in order to have effect of those drugs, you need to have the immune cells, you need to have the mutations and neoantigens, otherwise the best immune therapy doesn't work. Now, when we started giving immune therapy, we gave pembrolizumab, atezolizumab, very similar drugs. And there are 3 things we can learn from those very first single agent studies. The first thing is, immune therapy has single agent activity in triple negative breast cancer. And we saw in about 1 in 4 patients it worked. But the second thing came as a bit as a surprise. If you look at the data here with different drugs, very similar data, good response first line, but poor response second or third line. And that came as a surprise to us initially. We thought, why is that? Because there shouldn't be resistance. But what we've learned is if you wait too long, the whole stroma becomes more and more immune suppressive. And if you give immune therapy too late, it's not going to work. The immune system is exhausted. The stroma suppresses an immune response. So if you give immune therapy, give it early on. The third thing we learned from there was if we give immune therapy and if it does work, it is often transformative. If you look at the median duration of response, so patients who responded had on average 21 months benefit of that treatment. And that's in the context of survival time of 15 months, so massively transformative. If you look on the right side, patients in green are the patients who had an objective response to immune therapy. They were all alive. In blue, patients who had stable disease, or in red, patients who had progressive disease passed away very quickly. So clearly, if immune therapy works, it changes the tumor, and that was single agent, but it was a little bit tricky to make that work in a wider field. Now, then we did a first phase 3 trial, and this was a trial in second or third line, giving single agent immune therapy, as you can see in blue, and compared it with chemotherapy. Now, when we designed this trial in 2013, we were super excited. But actually, with everything I shared with you right now, would you think this trial is positive? It's very difficult because it's second or third line where the response rates are very low. What we tried to look was overall survival, and we changed the design as we went along for different PD-L1 positive cutoffs, and I will explain this in a second. Now, you all heard about PD-L1 testing, and PD-L1 is not just a target of immune therapy, but it also tells us whether this is a mechanism that is effective in the cancer to stop an immune response. There are different ways, and it's really important, how we can test for PD-L1 expression. We can either check it on tumor cells, or we can check it on immune cells, or some tests check it on both. And that's the so-called CPS score, combined tumor and immune cells. We can also check just the positive cells or look, are there any clusters where we have a lot of positive cells? And we can different cutoffs. We use different antibodies. The two you need to remember is SP142. The other one is 2-C3 and different platforms. Now, why is that important? It's important because it's completely different to HER2 positive breast cancer, where it's all very, very transparent, all on the cancer cells. In triple negative breast cancer, most of the staining is actually not on the cancer cells. This is from our large trial where we used an antibody called SP142. We looked at who is positive, and as you can see, 41% of metastatic breast cancer, triple negative breast cancer, was PD-1 positive, but practically all of them have their positivity on immune cells, not on cancer cells. If you look at the actual tumor cells, it's only 9% positive. That's very different to, for example, lung cancer, where half of the tumors are strongly positive on tumor cells. It's a very different biology in breast cancer, and that's why the assay is so important. Now, if you use a different assay, if you use rather than SP142, if you use, for example, the 2-C3 assay and use a cutoff of 1 in the same way as we use for SP142, you got 80% positive rather than 40% positive. So completely different assays. And that's really important when you look at the trial data, because if you use the wrong assay, they don't make sense. Now we're going back to the trial I just shared with you, the randomized trial between single agent immune therapy and chemotherapy as a second or third line treatment. So where we expect a low response rate of immune therapy. And as you can see, all patients taken together, there's no difference. But you could also say immune therapy, actually, even if it doesn't work terribly well, is as good or bad as chemotherapy. Now, if you look at patients who have a low cutoff for PD-L1, start separating a bit. The higher the cutoffs get, the better it is. And if we use an exploratory group of patients where the tumors are very strongly PD-L1 positive, there we possibly even have a survival benefit of immune therapy in single agent and in second or third line setting. If I show you this in a slightly different way, we look here at what we call the immunogenicity, so the ability of whether the immune system is already switched on or not in the cancer. Up here, it's not switched on. Down here in green, it means the immune system is switched on. We also look at TILs, lymphocytes, immune cells in the cancer. Again, in all patients relatively low. In the group of patients who have CPS 20, it is very high. And that's a small group of patients compared to ITT. But what happens in that small group is the response rate is very high, and those patients have a survival benefit. So what we learned from the single agent study is there may be a very small group of patients who benefits from single agent therapy, but the majority of patients will require combination therapy in order to make immune therapy work. And this is where we then went on and started doing the first combination studies. So the first combination trials we tried to do were chemotherapy and immune therapy. And you may say that doesn't make sense. Chemotherapy is immune suppressive, and would say, actually, it's not. Chemotherapy can be a form of immune therapy. Chemotherapy, as you can see on the slide, breaks up the surface of the cancer. It releases the antigens for the immune system to see. It brings down the Treg cells, which are like a foot brake in the immune system. And it increases PD-L1 expression and CD8 positive cells. So there's lots of positive effects. And that's why we combined chemotherapy and immune therapy. But that's not going to be the end of the story. So what we have seen is the first generation studies, and they are positive, and I will share the data with you. But we are working on now is second and third generation, where we try to improve on this, bringing in small molecules, bringing in immune therapy combinations. So the first phase 3 trial we did in combinations, the first positive trial ever in triple negative breast cancer for survival, was the Impassion 130 trial, as you heard before. And that was a phase 3 trial in first-line setting, so early on. And all patients received nab-paclitaxel chemotherapy. The reason why we chose that was at that time we were anxious about giving steroids. We thought if you give steroids, immune therapy might not work. We have since learned it probably doesn't play a huge role, but that's why we chose nab-paclitaxel rather than common paclitaxel. And then we looked at two main endpoints: progression-free survival, so the time until the cancer grows, and overall survival. And for each of those endpoints, we looked in all patients, and we looked in PD-L1 positive patients because we didn't quite know at that time who would benefit from that treatment. And you may have seen the data. If you look at progression-free survival in patients who are PD-L1 positive, and PD-L1 positive was this SP142 assay, 1% cutoff, 40% of patients. And you can see clear separation of the curve. Hazard ratio, that's always important, 0.62, clear benefit. There was still a benefit in the ITT population, all patients, but when we looked at patients who are PD-L1 negative, it's clear they have zero benefit of the immune therapy in this trial. The same applies to overall survival. If you look at overall survival, and we see a hazard ratio of 0.71 in PD-L1 positive patients, clear benefit. And if you look at the median here in blue, 25 months. It's the first time we passed the 2-year boundary and threshold, and really patients are deriving a substantial benefit. But if you look at PD-L1 negative patients, no benefit in this group. Now, how do we best test for PD-L1? One of the questions that always comes up: can we take the primary tissue, or do we need a metastatic lesion? And the answer is it probably doesn't make much of a difference. If you look at half of the patients had tissue taken from the primary tumor, as you can see in the right top corner, and the rest from a metastatic sample. And if you look at benefit of immune therapy, so the relative benefit outcome for PFS, progression-free survival, and overall survival, you can see there's no difference in the upper row whether they had the tissue taken from primary tumor, or the bottom row from metastatic disease. So again, I would be very pragmatic. If you have access to the metastatic tissue, test it. If it's PD-L1 negative, I personally go back and test the primary tumor. If one of those two samples is positive, we treat patients. What's also really interesting is you look at the right bottom corner, PD-L1 status by anatomical location. And the one thing we noticed is patients who have liver metastasis, they do as well as patients without liver metastasis. But if you take a liver biopsy, it's very often negative. So if you have a choice between taking a biopsy from a lung and a liver lesion, I would always go for lung, because it's much more likely to give you a positive result, which allows you to give immune therapy to these patients. We also compared the different assays. And if you look at the 2-2C3 assay here, the different assay, which is often positive when SP142 is not positive, patients have no benefit. So if you give atezolizumab, then you should use that assay that describes the benefit. The second study we just presented 3 weeks ago, it's very similar. It's now also in first line, is also using chemotherapy. It's used pembrolizumab rather than atezolizumab. There are 2 or 3 small differences which are worthwhile mentioning. The first difference is because when we started Keynote 355, we had already learned a little bit more about immune therapy. We said we can move away from nab-paclitaxel and also allow other chemotherapies. So patients and doctors could choose between paclitaxel, normal, or nab-paclitaxel, or gemcitabine and carboplatin. And that's really important. Because of that, we could also allow earlier relapses, who relapsed with at least 6 months after surgery, rather than everyone who relapsed only after 12 months. And again, that's interesting because it allows us hopefully to treat more patients. The third thing that's different is the biomarker. And rather using the SP142, which I just spoke about, we used the biomarker called 2-2C3 with a CPS score with different cutoffs, and I will explain that in a second. Now, the trial is positive. At the moment, we only have progression-free survival data. And if you look at the progression-free survival data, it's clearly positive in the group with CPS 10. Now, that group is very, very similar to the SP142 group, and it's about 40% of patients. And if you look at the hazard ratio, 0.65, that's practically identical to what we saw in the IMpassion130 trial. If you look at patients with other groups, CPS1, which is it's a bigger group of patients, but has less PD-L1 expression, the curve still looks separate, but that p-value is no longer statistically significant. And if you look at all patients together, again, very similar to what we saw in IMpassion130, hazard ratio of 0.8, but it's no longer significant. So clearly the trial shows practically the same as we saw in IMpassion130, about 40% of patients benefit from immune therapy. If you look at the 2 important subgroups that are different, do patients with platinum benefit? I would say yes. Do patients with earlier disease recurrence benefit? Again, I would say yes. So that allows us now to use different chemotherapies as well, not just nab-paclitaxel, and also allows us patients to relapse between 6 and 12 months after chemotherapy, not just after 12 months, which is really important to patients. So where do we stand with immune therapy in metastatic breast cancer? We got atezolizumab approved based on IMpassion130. We got Keynote 355 positive again for PD-L1 positive patients, but allows different chemotherapies, and it also allows patients who relapsed a little bit earlier, which is important. And 2 other studies will get data not too distant, the distant future. IMpassion131 uses conventional paclitaxel with atezolizumab, and we will hopefully see data at ESMO. IMpassion132 is still ongoing. It's the very early relapses with platinum or capecitabine as chemotherapy, which we will hopefully see in the next couple of years. Second line study, as I shared with you, Keynote 119, was negative. So immune therapy really should be given in the first line setting. But just to wrap this up, because I know I confused you slightly with the different PD-L1 tests. Now this is all, the circle illustrates all triple negative breast cancer patients. And blue is the SP142 assay, which is positive in 40% of patients. Now what's interesting, if you now look at the CPS 10 score, it's a different assay, which is positive with pembrolizumab. It's also positive in 40% of patients, but it's a different 40%. And as you can see, they overlap in about 75%, but it's now going forward worthwhile, if you have access to pembrolizumab, to do both tests, because there are 10% of patients who are negative with one assay and positive with the other, may still benefit from immune therapy. And I think that's really important for our patients. What about early breast cancer? We spoke about neoadjuvant therapy initially, and we did, and we've just introduced immune therapy in early breast cancer as well. We did a couple of small studies, which I'm not sharing with you, where we showed good path-CR rates of chemotherapy when added to neoadjuvant preoperative chemotherapy. But the key trial was really KEYNOTE 522, which we presented last ESMO, so 9 months ago. And this is a trial in patients who are either node positive or have a tumor of at least 2 centimeters size. And that is actually the majority of the patients we do see. And these patients received intensive chemotherapy, carboplatin and paclitaxel, which I do think should be standard, and then followed by 4 cycles of AC or EC chemotherapy. So 6 months of chemotherapy. And this either with placebo or in green with pembrolizumab. And after surgery, patients continued with adjuvant therapy the same way, pembrolizumab or placebo alone. The study has 2 endpoints and 2 ways of telling whether it's positive or not. One is looking at path-CR rates, which is the early endpoint, where we see is the cancer really gone. The second endpoint is what we call event-free survival, looking at recurrences over time and see, do those cancers improve? And there, it is a little bit too early to have definitive data. Now, if we look at the path-CR data, I think it's really important to put this into context. Now, with anthracyclines and taxanes, which many of you will use, path-CR is usually at around 35 to 40% in randomized trials. Where if we add in platinum, we get this to around 50%. And that's what we saw in the trial. We have the control arm 51% path-CR rate. But if we add pembrolizumab to this, it goes up to nearly 65%, highly significant, 13.6% difference in path-CR rate. That's massive. That's absolutely massive. And that should hopefully translate into a long-term benefit. Now, if you look at this in some of the subgroups, in particular in patients who have node-positive disease, if you look on the right, there the path-CR rate goes up from 44 to 65%, more than 20% difference. And again, that's massive. In my opinion, patients who are node-positive should definitely be considered for that treatment. What about PD-L1? Because we included PD-L1 positive and PD-L1 negative patients. And PD-L1 positive patients, you can see clearly with a CPS score of 1, 14% difference, clearly positive. What about PD-L1 negative patients? PD-L1 negative patients, if you look at the difference, the added benefit of immune therapy, that's the same, possibly even higher. The overall response rate with chemotherapy is lower. We have known this. Patients who are PD-L1 negative have less immune cells in there, less TIL positive, therefore respond worse to chemotherapy, but they still get the same benefit of immune therapy. What about if you use different cutoffs for PD-L1, 10 or 20, as we showed in the other trials? There's no difference. So we would say in the early setting, neoadjuvant disease, that's completely different to the metastatic setting. There's no difference in PD-L1 response, at least for path-CR. And you may ask, why is that? And I would say we don't know, but my theory is the tumors are very plastic. They can change very quickly in early disease. And we have done studies, data, and we will probably present them in San Antonio. If you give immune therapy for 2 weeks, we can turn a lot of tumors from PD-L1 negative into PD-L1 positive. And therefore, what is classified here as PD-L1 positive and negative can change very, very quickly. That's different in metastatic disease. Once the tumor is that established, we are not changing that anymore. And therefore, in metastatic disease, it is really PD-L1 negative is negative, PD-L1 positive is PD-L1 positive. What about long-term outcome? Have you got any data there? Well, we've only got 15 months follow-up. That's short for any adjuvant data. But as you can see, the curves are already starting to separate. If you look at the 18 months estimated event-free survival, 91% versus 85%, that's 6% difference. If you look at the hazard ratio, 0.63, that's incredibly encouraging. It's not yet significant at this very, very early time point, but we will have more data probably in the next few months. And I'm pretty convinced it's going to be positive at that point in time. So where are we heading? If you bear with me another couple of minutes, where are we heading with immune therapy going forward? Obviously, it's standard in metastatic TNBC, PD-1 positive patients. It will be standard in early triple negative breast cancer. But one of the things we are learning is it's not all patients benefit in the same way. There are some cancers, if you look at the slight purple color, the light blue color is the cancer, and the purple dots are immune cells. There's some cancers we have a lot of immune cells around there. And these are what we call inflamed or hot cancers. And it probably needs a tiny little nudge just to get the immune system going in those cancers. There are other cancers where we see immune cells, but they sort of hover around the cancer and can't really get in. And they are excluded in filtrate. We apply different strategies. And there are some cancers where we find no immune cells at all. What we're doing is we develop different strategies going forward. The inflamed cancers, that's Impassion 130, works really well as your standard at the moment. If you look at the excluded infiltrate, we are, for example, giving VEGF inhibitors, bevacizumab, but also I want to point your attention to AKT inhibitors again, and I will share some data with you, which are really promising. And in the cold cancers, again, we need to see if we give triplet combinations, can we bring out those neoantigens, or do we need to do cell-based therapy or vaccination? So just one little example of where the journey is going to. This is a study we have been working on for 2-3 years now. I presented some data at ASCR last year. We have many more data now. And this is the first triplet. So doublet was Impassion 130, paclitaxel and immune therapy. This is paclitaxel and immune therapy, atezolizumab, and then a third drug given on top of it. In this case, we use the AKT inhibitor. The reason why we do this, because the AKT inhibitor may change the MHC class 1 expression, it may bring in more immune cells, it may make them less exhausted, and so far is promising. Now, if you look at the response rate we had with chemotherapy in Impassion 130, was 43%. When we added immune therapy, was 53%. So this 10% difference in the response rate led to this large survival benefit we had in the trial in the end. Now, if you look at the very early data we have of the triplet with chemotherapy, immune therapy, and AKT, you will see we have a response rate of about 73%. Now, these are small numbers of patients, but as you can see in the waterfall plot, practically every patient did respond in our initial cohort. And that is in patients who are PD-1 positive or PD-1 negative or biomarker positive for AKT or not. And that's something we have now turned into a large phase 3 trial called Opportunity 170 with a large group, 600 patients in PD-1 positive patients, 600 patients PD-1 negative, to really see is this triplet going forward and going to be the next big thing that takes immune therapy not just into PD-1 positive tumors, but also into PD-1 negative tumors. The last thoughts in terms of slides I want to share with you is also how do we get a handle on all these new combinations? How can we make sure we test them properly? Well, this is one of the studies Zach knows very well. We're running at Barts. It's called Eclipse, and it's a preoperative window study. What we're trying to do here is it's an international platform we set up. Patients who still have the tumor in their breast, we take a biopsy, and then we give different immune therapy combinations for 2 or 3 weeks, and then we take the tumor out. And in those 3 weeks, we're not looking at proliferation, but we're mainly looking at immune markers. We're looking at CD8 positive cells, which drive the immune response, and then sequencing the cancer, looking at all sort of clever biology, including microbiome, to really work out which combination works best and in which patient may it work. And that's then linked with metastatic trials we do, which will ultimately allow us to deprioritize the next generation of immune therapy combination. So where are we with triple negative breast cancer, and where will we be? This is the slide I showed you at the beginning, and this has already changed in the last 3 years. We now have a new standard in pink, chemotherapy and immune therapy in PD-1 positive patients. We've also have PARP inhibitors now in first, second, and third line. They work very well in second and third line. That's why I personally give them second and third line. We have now chemotherapy and immune therapy in the neoadjuvant setting. We will have AKT inhibitors without immune therapy in the next 12, 18 months, positive, I expect phase 3 trials. We get PARP inhibitors in early disease. We got sagituzumab, now licensed in a third-line setting, and we have antigen receptor targeting drugs. So the treatment for TNBC is changing very quickly, and I would say is changing dramatically at the moment. And I hope you will agree that it will give us a lot of hope going forward that this subtype of breast cancer will be treated well in the future. Thank you very much.
Thank you, Professor Peter. So when the presentation started, we knew that TNBC is a hopeless situation. Now we can see there are quite a few many rays of hope. So as you mentioned that this is a platform we organize for the juniors and the mid-level, but today we are fortunate that many of our senior colleagues joined us today. So today we want to deliberately skip our case discussion session, but today we want to keep the question answer session. So now I would request our colleagues, the floor is open for question answer. So please unmute yourself and identify yourself and ask the question.
I'm Dr. Arunangshu, sir.
One, please.
Sir,
Altaf.
I have a question.
Is the video shared?
Hello.
Yep.
Sir, can I ask a question?
Yes, please. One by one. We are first I saw Riyadh, then Lima, then you. Okay.
Okay, thank you, sir. Sir, my first question is to our first speaker, Dr. Arunangshu, and my question is, as availability of BRCA testing is not so far in our country, so can we use platinum regimen in every TNBC, or should we use platinum regimen in every TNBC? Or if not, then which patient should we select?
Arunangshu. Arunangshu,
Yes, you're
there, please.
absolutely right. We cannot check BRCA status in all patients, but as I have already said and showed in the guideline, when we are giving neoadjuvant chemotherapy for a TNBC patient, we should definitely consider adding platinum to it. And also, it has become a practice that all patients, along with taxanes, either it's a docetaxel or it's a paclitaxel, we should add carboplatin to have better results. Right at this moment in our country, we're not seeing whether it's a BRCA positive or not, but we are trying to add carboplatin along with the paclitaxel.
BRCA is available in our Hello?
Professor,
BRCA is available in our country. Hello?
Yeah, BRCA is available. Not ready level, but it is available. It can be done.
But I think we need to be very clear. Platinum is not a BRCA story. And
Yes.
it's really important. If you look at the TNT study in metastatic disease, in all patients together, platinum was as good as a taxane. But in patients who have BRCA germline mutations, it's twice as good as a taxane. So platinum is an effective drug. And I personally would, at the moment, treat the vast majority of patients in early disease with the platinum combination. Because the PAF-CR rates are higher, it doesn't add much toxicity. It's a cheap drug as well, and is highly effective. The guidelines are a little bit lagging behind there. And if you look at NCCN, I don't think it's terribly helpful. They are not that great for triple negative. So our guidelines amongst triple negative breast cancer experts are very clear. If you give neoadjuvant therapy, always consider adding platinum in there, because it is more effective, irrespective of whether they are BRCA positive or not.
Thank you, Peter. So Shahida Alam.
So my question is to Professor Peter. And first of all, that was a splendid presentation, and we're so proud to have Professor Peter with us. So in his landmark study, Keynote 522, there was not much significant difference in PAT-CR when PD-L1 positivity or negativity was concerned, which was completely different in impression 130. So my first question is, would it be rational to offer the patient in early stage breast cancer without doing the PD-L1? We can offer immunotherapy the patient without doing the PD-L1 testing in early stage breast cancer?
So in early breast cancer, yes. At the moment, we don't need the PD-L1 status. It doesn't inform us, and so patients benefit in the same way. It's also what I try to say is I think the PD-L1 status changes very quickly in early breast cancer anyway. If you take it at baseline, it may be different 3 weeks later. So yes, in early triple negative breast cancer, you do not need PD-L1 status. In metastatic disease, you do.
So my second question is also related to that. So PD-L1 is not the right target for selecting the patient in early stage breast cancer for immunotherapy. So should we be looking for another targets like PD-1 and the TIL, then isolated tumor infiltrating lymphocyte? This would be some targets for selecting the patient for immunotherapy. What do you think?
So at the moment, I would not outside trials. Obviously, we run a large translational program in the Keynote 522 trial, and we will do mutational sequencing. We do our RNA-seq. We have other immunohistochemistry marker, including TILs, as you mentioned. And I think they will all show us probably a little bit, but my suspicion is we may not be able to find a group where it definitely doesn't work. But so at the moment, I would say outside trials, we have no way of deselecting patients, almost saying you don't need immune therapy. But we are working on that and doing other tests. TILs are clearly not better at the moment than PD-L1, because your PD-L1 test is essentially a TIL test anyway, because most of the PD-L1 staining is on immune cells.
Okay. Thank you for.
So I think Breast Cancer Foundation, Alina Fisa had a question.
Thank you, sir. Assalamu alaikum. Sir, my question is Arunangshu, that why we advised the genetic testing after recurrence of the triple negative cancer? Why not before, when we first time diagnosed that this is a triple negative and patient age is less than 60? Why not then? Why after recurrence? What is the significance of this?
No, actually the rebiopsy, when we are saying we should check PD-L1, definitely you are absolutely right. BRCA, if it is a TNBC, we should do earlier. Currently not being practiced for, in Bangladesh it's available, but limited. Yes, BRCA status should be checked if a TNBC patient is diagnosed. I agree.
Thank you, Arunangshu.
My another question to Peter.
Okay.
One patient, 50 years old, 1.3 centimeter tumor with node negative, grade 3 triple negative patient. What is the treatment modalities? CT first or surgery first, or what CT we have to choose? Hello?
So I would always give surgery first in a tumor that's more than 1 centimeter in size. I would always give chemotherapy first. We would routinely give chemotherapy to those patients anyway. If you give chemotherapy before surgery, you have 2 or 3 advantages. The first advantage is you see whether the patients respond. If they respond well, they have a fantastic outlook. If they don't respond, we can give adjuvant capecitabine, which reduces their mortality by 42%. The second thing is it gives us time to do BRCA testing, which allows us to fine-tune the surgery. If they're BRCA positive, then obviously a lot of patients go for risk reducing surgery. And so I think it's important. Also, if you think about the axilla management, if you have a patient who has, so we don't do an upfront sentinel lymph node anymore. If you do have a patient with a fantastic response, and she is node negative in the axilla, you only do a sentinel lymph node biopsy. You used to have patients with 1 or 2 lymph nodes where you then need to think about doing a full clearance and increasing morbidity as well. So I think these are small benefits, but ultimately I would personally, if you give the chemotherapy anyway, why would you give it afterwards and take away those benefits.
Thank you, Peter. I have one question regarding the neoadjuvant setup. You have shown a wonderful path here with immunotherapy and chemotherapy. So why to continue the immunotherapy? You say it's an issue of cost. So we had received paths here, and normally we don't give any adjuvant treatment when we achieve paths here. So why not to stop here? Why to continue?
Yeah, it's a good question, and the honest answer is we don't know. So we kind of matched a little bit what we have been doing in HER2-positive disease, where you give the antibody for a year, but no one knows is 6 months enough or does it need to be longer. And in HER2, we did this very impressively. We did 2 years. It's not better than 1 year. 6 months is probably as good as 1 year, but we're still trying to prove this. My gut feeling here is that if you give it before surgery for 6 months, that's probably enough. And I'm not convinced the 6 months of adjuvant therapy add a lot. But this is the way we did the trial, and a trial is always a compromise. And we will find out over the years whether or not the adjuvant part adds something or not. I would personally not be surprised if we found the adjuvant part adds relatively little, but no one knows the answer.
Thank you. I asked Mustafa Aziz. I think you have 2 questions you mentioned. Can you please ask Mustafa Aziz?
It's a dream to talk with Professor Schmid. Professor, I have 2 questions. Number 1, regarding your keynote 522, which was presented by you in last ESMO. In that presentation, the decision was based on totally on complete pathological response. The ejection-free survival was not statistical significance. So in the session, your answer was that the very high power rate failed to.
Yes,
Shimon, we cannot hear you. Shimon, we cannot hear you.
Significance right now regarding.
Mustafa, can you please repeat? We didn't hear your question.
So in last ESMO presentation, Professor Schmid declared that he failed to statistical difference in ejection event
survival.
EFS. EFS.
Yeah.
Okay.
I mean, let me try and answer this. So obviously, PAF-CR is a very established endpoint for triple-negative disease, and we have data from the large FDA meta-analysis showing that if you have a PAF-CR benefit in triple-negative breast cancer, that's highly linked with the event-free survival and overall survival benefit. The hazard ratio of the link is 0.24 with event-free survival, 0.16 with overall survival. So in other words, patients who have a PAF-CR are very likely, from everything we know from chemotherapy, with a long-term benefit. Now, we don't know whether that's the same with immune therapy, but everything we have seen so far is that immune therapy, you have less of a response and more a time benefit. So when we designed Keynote 522, we thought we may not see a benefit in PAF-CR, but we thought we will still see a benefit in event-free survival. Now, everyone will probably agree that 15 months follow-up is very, very short for any adjuvant trial. And if after 15 months, we had very few events. And all we felt was we take a very early look at the data. And in order to be positive, the trial had to have a p-value of 0.00005. And we missed this just about. Had we chosen a p-value of 0.00003, we would have the trial would have been positive. So strictly speaking, absolutely, this trial is not positive for EFS at this point in time. But this was the sort of, as one of my colleagues said, a cheeky early interim analysis just to look there. And we didn't want to spend much alpha there. The proper analysis will come in a year or two when we have seen more recurrences. And and we don't have the answer yet. I would be very surprised if it was not positive. If you already see the curve separating, if you know you have a better path CR, it's very, very likely, not guaranteed, but it's very, very likely to be positive over time. But we need to wait a little bit longer for that.
Thank you. My second question. So we are very optimistic with the positive PCR group, but even with the keynote 522, there is still a significant percentage of patients, those who fail to achieve PCR. So what option we can consider for those patients who fail to achieve PCR, even with immunotherapy?
Yeah, I think that's a really, really important question. And so I hope I understood it right, but patients who don't have a puff CR, what do we do with them? And to be honest, I shouldn't say that, but we always thought about taking them off study and give them capecitabine. So I think if you don't have a puff CR after this intensive chemotherapy, I would still think about capecitabine, but these are patients who have a fairly high risk of recurrence. We think, we don't know yet. There's still the hope that patients who had immunotherapy may do better even if they have not achieved a puff CR. That's one of our hypotheses, but we don't know that yet. And the reason why I say that is if you look at the early relapses we've seen, these would have been in patients who have not achieved a puff CR. And so maybe we see a benefit of immunotherapy even in the non-puff CR patients, and we need to learn whether non-puff CR with immunotherapy means the same as non-puff CR with chemotherapy. But until we have learned this, I personally give those patients capecitabine.
Do you think that Persiflage trial can be an hope for the patient measuring the circulating DNA or circulating tumor cells based on the Persiflage trial?
Which trial, sorry?
Persiflage. They are measuring the circulating DNA, circulating tumor cells, and they are planning according to the investigator's choice chemotherapy regimes in one arm capecitabine, one arm atezolizumab, one arm PRP inhibitor. I am not sure, but there is a trial ongoing based on the circulating DNA.
So it's certainly in an area where we are all doing a lot of research, and we are trying to do a few studies of the non-puff CR patients. The drugs I would put in there are antibody drug conjugates, to be honest. Those are for me the most interesting drugs. But there are several strategies ongoing in terms of what drugs to choose. But also, you're right, we can also look at the super high-risk patients who still have circulating DNA present. So one is how to select the patient, the other one is what treatment to give. And I think the key thing is to give effective treatments. For example, ADCs are the way forward there, I think.
Thank you. Thank you, Doctor.
May I ask Professor Hussain to make the comment? Professor Mufazzal.
Since I am in the chamber doing some clinics as well and listening to the presenters, so I do not want to show my ugly face now because I am with mask and all PPI, right? PPE. So that was excellent presentation, Professor Peter. I actually had some work on triple negative breast cancer, and you must be knowing Dr. Rebecca Dent in Singapore, NCC.
She's a great friend.
Do you find any regional variation or ethnic variation in the prognosis of the triple negative breast cancer?
So Rebecca and I speak a lot about this, and I get the impression there are some differences. So when we looked at some of the targets, for example, the PIK3CA, AKT, 10 mutations, our impression is they are slightly higher in parts of Asia compared to, for example, parts of Europe. Also sometimes Rebecca and I often talk and share cases, and some of the aggressive cases Rebecca sees she sees them probably a little bit more often than we do. So I do think there will be differences, and I think that's not a surprise if you think about this heterogeneous disease. and at the moment we are not characterizing it well enough. And in the same way, I think where it's well established in American studies, if you look at Afro-Caribbean population compared to a Caucasian ethnicity, that the different breast cancer subtypes are different between different ethnic backgrounds. And I think we may see something very similar. We just can't, as we don't subdivide yet into TNBC, into different genomic or other risk classifications, we probably are not aware of this enough. But I do think the ethnic background has an impact on what subtypes of cancer we may see, and often there's obviously then also the environmental impact as well. So I do think there are differences. Yes.
Thank you, Peter. I have a junior colleague. We are selecting the question which is coming to the chat box. Dr. Debraj Chakraborty, he wants to ask some question. So anybody interested, please put the question in the chat box. We will call you. Dr. Debraj.
Thank you, sir. Am I audible, sir?
Yeah, please.
My question is to Professor Peter Schmid. Thank you for your excellent presentation. You said at first in patient 130, you used to have immunotherapy with nab-paclitaxel with the thought of not using steroid as it can suppress the immune system. Then why not using it afterwards, or why it is not considered in Keynote 355?
Because so I've often said, Keynote, when we designed Impassion 130, no one believed immune therapy would work in breast cancer. And so our goal was to have a positive trial. And there was a debate in 2013 whether steroids impact on the immune response or not. So we said, let's just do a very pure design. If this trial is negative, I don't want it to be negative because of the steroid, because that would have been the last trial we would have done. And so that's why we chose nab-paclitaxel. Now then in 2014, 15, 16, we got gradually data coming through from lung cancer in particular, where obviously other combinations are being used that often require steroids, and patients still had a benefit. And so we then felt, actually, if it works in lung, it probably works in breast. And we did then other studies in breast where we see it seems to be okay. And for Keynote 355, we just said, let's do this differently. And it's as always, you take a risk. And but it was clear that it didn't make sense to do the same study again. And therefore we said, we'll do a different study. One of the I wouldn't say weaknesses, it was actually one of the strengths of Impassion 130, but one of the weaknesses in terms of daily clinical practice is that it uses nab-paclitaxel. And we said, let's try something different. And that's how it went. We got more confident, and the data support that. And for Keynote 522 in the neoadjuvant setting, we did a phase 1b study, which I didn't share with you, called Keynote 173, where we had 6 different regimens we looked in, some with paclitaxel, some with nab-paclitaxel, weekly, 3-weekly, carboplatin, just to see, do we see any massive differences, small numbers. And again, it seemed to be making no difference whether we used paclitaxel or nab-paclitaxel. And so we then went ahead in Keynote 522 in the neoadjuvant setting with conventional paclitaxel. And that's just how it is. I think it's more a historical explanation. If you look back at it now, so if I was doing Impassion 130 now, I probably would do it with just paclitaxel. But that's why we then did Impassion 131 to do the same trial again with paclitaxel. And from a patient point of view, it was probably the safest to have it in separate trials, because if the trial is negative because of steroids, you kill the whole disease and the whole treatment. If now Impassion 131 is negative, then we'll say, well, maybe the steroids play more of a role.
Thank you very much.
So, Dr. Sharif, I think you had a question. Dr. Sharif, in the chat box, you asked to ask a question. Are you there? If not, then we move to Dr. Riyad. You have a question, Dr. Riyad.
Yes, sir. I have a question to Professor Peter. Sir, you have we shown that both pembrolizumab and atezolizumab are showing good result in PD-L1 positive patients. So, is there any scope to compare between these two drugs? Which one is better?
I wouldn't do it. I don't. I think we have more important questions to answer. Whether drug A is better than drug B. They are very similar, and the results look almost identical. I think our focus needs to be how can we make the results better. So can we? And that's why I shared with you the concept of the triplet, where we say in PD-1 positive, if we add a third drug, can we do this better, or can we make it work in PD-1 negative? But I personally am not convinced it makes a huge difference, and I wouldn't. I would feel that's commercially relevant, but scientifically less relevant whether we compare pembro with atezo.
Thank you. Anybody else? You have a question? Dr. Peter, what I can tell that you are facing ESMO and ESCO and you are facing great oncologists, but today you are facing some junior who will be a great oncologist in future. So it's a totally different experience they're having today.
I think it's always great because it shows how we're all learning very quickly, and what I shared with you today is basically the journey of 7-8 years of trials. So 10 years ago, none of that existed. 10 years later on, it's a different world, and we all will have to grow in that world as well. And in 10 years' time, if you think back to this talk, we'll think, well, this sounds like Stone Age. And we hopefully have moved on much further.
So thank you. I think if we don't have any more questions, we can stop the question answer session here. And,
Sir, I have a question.
Oh,
Dr. Nusrat.
Sorry, I missed your question. Yeah, please, you have a question. Sorry.
Sir, I'm really very thankful for participating in such a wonderful CME at the tough corona time. Thank you, Peter Schmid, for attending us. My question is to my senior teachers. As we are a less resource country, always we can't do the BRCA or PD-L1. So, what drug we will give, PARP inhibitor or PD-L1 in metastatic breast cancer?
So, Peter, can you help us? Then maybe we will try to make some comment. If we cannot do this test, well, how can we proceed?
So I can answer this in different ways. If you have access to both, to PARP inhibitors and to PD-L1 drugs, which one do you give first? I personally give the immune therapy first. The reason for that is the data I showed you suggests there's a survival benefit, and the treatment works best in the first line setting, whereas if you give it in second or third line, it may not work that well. If you look at the PARP inhibitor data, they haven't shown a survival benefit, but they work very well in first, second, and third line. If you look at the first line response rate, it's just over 60%. Second line is 58%, third line is 52%. So actually patients still respond very well in a second or third line setting. And that's why I would prioritize first immune therapy, then PARP inhibitors. Now, if you're in a situation where you can only afford one of the two treatments, well, that's also an important thing. And then I personally, again, would choose immune therapy. The reason for that is I have no other drug to replace the effect of immune therapy, but platinum gives you a large amount of the benefit of PARP inhibitors. There's a lot of overlap between platinum and PARP inhibitors. Therefore, if I can only ever use one of the two and then we run out of money, I would choose immune therapy.
Thank you, Peter. You helped us to answer the lady, because these young people are asking really dangerous questions. So, Dr. Riyad.
Sir, thank you again. Sir, my question is, as we can't do BRCA mutation test in our country regularly, so is it rational to use olaparib or PARP inhibitor routinely in case of metastatic TNBC?
Without doing the test?
Yes, sir.
Peter.
Well, you can't do it without the test, but I think it's a question of time. So in the UK at the moment, we use PARP. I can use PARP inhibitors only for private patients, in the NHS, it's not yet reimbursed, and that will come, but at the moment it's not funded. And so at the moment, because it's not funded, the PARP inhibitor, we don't test every metastatic patient for BRCA mutations. Once the treatment is funded, we will get access to testing. Getting access to testing is very simple if there's a treatment available. So our experience is the same with SP142 and immune therapy. 2 years ago, no one could do the test. And then we got a drug that's funded and needs that test. And within a few weeks or months, we sorted out the testing. So you need to have access to the drug. Once the drug is reimbursed, someone will pay for the test. That's my experience.
Thank you, Peter. For Riyadh, my answer is that you see the cost of test is not that much, but the drug is costly, and we should not use this type of sensitive, targeted drug without knowing really whether it's a target or not. Empirical treatment is no more this world. Okay, yes. Sherry, you had the question. This is the last question we are going to take, then we will move to
It is really privileged to talk and hear from the Professor Peter. I have a question to Professor Peter. That any role of NTRK fusion targeted therapy in TNBC?
So I would say hopefully, but the incidence of those fusion mutations is less than 1%, and that's what we've seen from Foundation Medicine results. So I think at the moment it's just not realistic to test for it. I think in 10 years' time, if we have more targeted therapies and do more next generation sequencing, including fusion gene analysis, we will identify those patients. And yes, I think there's a small group, but it's less than 1%.
Thank you, Peter. So thank you to all the... Anybody?
Can I ask a question? Thank you, Peter and Arunangshu, for your very nice presentations. I have a question to Peter. Pembrolizumab, can pembrolizumab be used along with radiation or after radiation?
Yeah, it's a good question, and at the moment, I think in theory it can. It comes. I would always ask how good is your radiotherapy setup. Now, the risk of pneumonitis is a little bit higher with immune therapy, but if you have a good planning and spare most of the lung, then it can be given at the same time.
Okay, thank you very much.
So, if I'm allowed, I think today we have only selected the person who has put their name in the chat box to ask the question. We didn't invite voluntarily anybody to make any comments because we encourage the juniors and the interested person to take the opportunity to interact with Peter Schmid. And that's why I think we have, I saw many faces of many senior colleagues, but I didn't ask them to make any question. So I see the Dr. Armand Reza to Professor Peter. Do you have any opportunity to include oncologists to add clinical trials from Bangladesh? Can you add anybody to be a volunteer to be part of your study, to add patients from Bangladesh?
We would love to. The reality is always, it comes with the big trials comes down to cost. And often, so I always, I haven't got control over which countries get selected if it's a big study we do with Roche or Merck. What I've done before is if there are countries I've been to and I know the system works very well, then we can push them and say, why don't we include this? The world is unfortunately very cynical there. And what companies look for is where can we recruit well with good quality cheaply, but also where's there a market afterwards to sell the drugs, and whether that's fair or not, that's not necessarily relevant in those decisions, and I don't like it. But I travel a lot in the Middle East and in Asia, and I think Bangladesh should possibly be, in my opinion, in a stronger position than many other countries I travel to, because you're a big country. If I go to some of the smaller countries, then they will struggle because no one will open a trial for a country with 5 million population or 10 or 15. because it costs a lot of money to do this. You're a large country. My experience is it makes it helpful for us if the cancer centers are big, because if you have a cancer center that sees 1,000, 1,500 breast cancer patients a year, and if you know the patients are well followed up, and it's not that they go after first-line treatment and go into a remote village and you lose contact, but then that's good because you have good data and it makes it relatively cheap to recruit. But it's those concerns we always need to address in the different countries, and there are a lot of often prejudiced, but we need to work on that together.
Thank you, Peter. My request will be that may not be the great this phase 3 trial, but we will be having a discussion with Dr. Zakirullah how to keep the data, as we are sitting on the tons of data in our country. May not be the great setup, may not be the great follow-up, but maybe we can discuss sometimes to have some very primitive type of study on the breast cancer in our country population under your guidance to start with. And who knows, maybe in course of time, we will mature ourselves to be a part of your, the main study. So now I want to stop here, and I want to.
I think.
Yeah, please.
I think that would be great. And for example, with some countries, we managed to establish.
Sorry.
Yeah.
Sorry, my internet I think was playing up. I think those things are good. That's why it's important to have a dialogue. So, for example, with Korea, I've been there very often, and we do a lot of trials with them and know a lot about their setup, and that allows us then to have collaborative studies. And I think those things are helpful. Establishing, if you know each other better, if you know the strengths and the weaknesses of each hospital setup, we have enough weaknesses in the NHS, then we can work out ways how we can work together better.
One thing is, just to add here, Peter, I did discuss with you that triple negative cancer is quite high in Bangladesh population. We don't know why. We need to find out. And obviously, the way the Oncology Club is working now, in future, I can see the prospect that definitely will be able to establish some sort of research facilities between you and Bangladesh population or Bangladesh oncologists, and we can work on that. And that's why I'm just going to give a little bit of lecture about how to compile your data. If you know your data very well, you can compile it properly, then we can show the rest of the world that this is the way it's going on. And definitely for triple negative cancer, we need your help in future. Peter.
Always happy to help.
Thank you. Now,
আমি একটু অ্যাড করতে চাচ্ছিলাম। Can I add something? কারণ স্যার আমরা 1.5 বছর ধরে ব্রেস্ট ইউনিটে একটা সফটওয়্যার ডেভেলপ করেছি, যেখানে আমরা কিন্তু ডাটা কালেক্ট করি, এবং এখানে একটা ক্লিক দিলে আমার ইআরপিআর কিরকম, কতগুলো পেশেন্টের কি, এটা আমরা করতে পারি অ্যানালাইসিস খুব ইজিলি। এবং এটা গত 1.5 বছর ধরে আমরা কন্টিনিউয়াস আপডেট করে যাচ্ছি, হয়তো আরো কিছু ভুল আছে। আপনি যদি চান আমরা এটা দিতে পারি, কারণ আমরা যে 1700 পেশেন্টের ডাটা অ্যানালাইসিস করে দেখিয়েছি, ওটা কিন্তু ওখান থেকে আমরা দিয়েছি। তো আমার মনে হয় এটা অনকোলজিক্যাল হোক বা সার্জন হোক, তবে হ্যাঁ শুধু ব্রেস্ট রিলেটেড
ইংরেজিতে বলো।
বিধাকর।
Okay, just to summarize, Amphisa was trying to say that they have got a data as well in their center, but of course it can be used for Bangladeshi people as well. So we'll look through that, and if that is effective for the Oncology Club as well, we'll definitely welcome them to come and join us as well.
So now we are moving to our quiz session, because normally we finish at 4:30. So we will quickly finish it with Professor Peter. We always run a quiz for our juniors. I mean, it is open for all, not for you maybe. I mean, everybody can participate. It's fun. And during the quiz, I will ask Farid to make some comment. When the link is given to the chat box, please give the link to the chat box. And Farid, can you make a comment, quick comment?
Thank you, Peter. It's an excellent presentation, talk, and it's brilliant, interaction. Just one quick query: where is you got this cutoff of 1 centimeter of TNBC patients deciding for neoadjuvant chemo? Would it be like 0.5, or because if your reasoning comes for neoadjuvant chemo allowing you to get genetic informations and prognostic information, the same reasoning applies for 0.8 centimeter or 0.5 centimeter cancer as well. So where did you get this 1 centimeter cutoff?
I totally agree. Totally agree. So I would happily give neoadjuvant therapy to an 8 millimeter tumor. But I think it's more. I think it's more getting it into people's heads. It doesn't start at 2 centimeters. My view is always, if you give chemotherapy, you may as well as give it before surgery rather than after surgery, irrespective of size. And I get a lot of people often fall out of their chairs if I say give neoadjuvant therapy for 1 centimeter. If I say give it for 8 millimeters, they will throw me out of the room. But I would happily do this. It's obviously if you decide, if it's a 35-year-old and it's 8 millimeters and decide to give chemotherapy anyway, then all the things apply the same way for 8 or 11 millimeters. You're absolutely right.
Absolutely, case by case. Thank you very much.
Pleasure. I think you're mute.
Questions, if you want to, if you click the chat box.
Kamal bhai, we can't hear you.
You can see.
I said that the quiz is on. The almost 1.5 minutes gone. So anybody wants to go to the chat box, go to the link and answer. 10 questions and $5,000 will be the award. So as we discussed, today we will skip our case discussion. Next week we will have the case discussion on TNBC. And there we will have a lecture from Farid about the breast surgery, how much a oncologist need to know. So we'll listen to Dr. Farid and also discuss the case discussion on TNBC next Sunday.
Thank you, Kamal bhai. I'll try to do that. And obviously, there isn't much evidence-based information as far as like there is no randomized trials or anything for various ethical and legal reasons for pregnant patients with breast cancer. So the number of cases are not very high as well. But whatever updated information and guidelines I've got available, I'll share. And then hopefully it will have a fruitful discussion next week. Thank you.
Less than 2 minutes time remaining, gentlemen.
Come on, today is John Coniver's birthday. So let's see whether I can actually connect him. Then we can unmute everybody so we can all together give him a happy birthday.
Zakirullah bhai. Zakirullah.
Tell me, yes.
You should have told us earlier so we can arrange
okay.
A virtual cake. You can arrange a virtual cake or a flower bouquet for him.
John is online. Can you hear us? Can you FaceTime you? Okay. Can you FaceTime? Look at the monitor now. So please unmute everybody if you can. Come on.
Lift your phone up.
1, 2, 3.
Phone upore tulen.
Can you see John?
Yeah, you can see John.
1, 2, 3. Happy birthday to you.
Happy
Happy birthday
birthday
to
to you.
you.
Happy
Happy
birthday,
birthday to
dear
John.
John.
Happy
Happy
birthday
birthday to
to
you.
you.
Peter is also watching. 21, I know that. You were 20 till yesterday. Just 21 now. Good. Have a very good day, John.
I thought he was 12, but
Yes.
thanks for confirming.
Okay, John. Enjoy. Okay. Same to you as well. Bye-bye.
You can send a flower bouquet to John with the help of Farid Bhai or Zakirullah Bhai
Yeah.
on behalf of Oncology Club.
Yes.
He's our very old friend.
Okay, so now during the result processing time, may I request our scientific partner, Sanofi Aventis, to say a few words, to give a vote of thanks.
Thank you, sir. Being scientific partner, it's my privilege to have been asked to propose a vote of thanks on this session. Dear Honorable Chairperson, respected overseas guest faculties, speaker, and other distinguished doctor and healthcare professionals, greetings from Sanofi, Bangladesh. Oncology Club always organizing regular CME and taking different initiatives to improve the skills and expertise of cancer caregivers with the collaboration of national and international resources. In the continuation of this era, Oncology Club organized the virtual learning platform with the involvement of local and foreign experts. Sanofi Oncology feels proud to sponsoring such insightful session. I would like to express our profound gratitude to our Honorable Professor A.M.A. Hai Sir, President of Oncology Club, for inspired us by his gracious presence. Heartiest thanks to Dr. Arunangshu, Associate Consultant in Square Hospital, for his excellent and elaborate presentation on the treatment modalities of triple-negative breast cancer, which is enriched with different guidelines. I would like to provide special thanks to Honorable Faculty, Professor Peter Schmid, for his valuable insight regarding triple-negative breast cancer. It's a great privilege for us to have Peter Schmid as a faculty. On behalf of Oncology, on behalf of Sanofi, I would like to express our gratitude to honorable foreign experts who blessed us with their gracious presence. Heartiest gratitude to Dr. Muhammad Zakirullah and Dr. S.K. Farid Ahmed for their expert opinion. I would like to give a special thanks to Dr. A.F.M. Kamaluddin sir, Scientific Secretary of Oncology Club, for organizing such fabulous learning platform and giving us opportunity to support the program. On behalf of Sanofi, I would like to give a special thanks to all participants for took up their valuable time from current busy schedule. We highly acknowledge your support and contribution towards society. Thanks to my colleague Nahid Hassan Abbas and especially Shahadat Hussain Rigan for their support to organize the program. With all of your support, we will continue the program in future. Till then, stay safe, stay healthy. Thanks for patience hearing. Thanks to all.
Thank you, Lucky. So may I request Professor Peter to make a comment how you enjoyed the time with us?
It was good fun. I always like that. And I think it's lovely doing this on a web-based way, because that brings us, it's one of the few positive things, well, it's the only thing I can actually think of, this COVID disaster has brought to us, is that it actually, from a scientific point of view, brought us a little bit more together, because where it's difficult to fly to all the places in the world, it's much better to have a quick Zoom call from your bedroom.
Thank you very much. So we are almost at the end of our session. So we are going to declare the award winner today. So any quick comment from Zakirullah Bhai?
Thank you, Oncology Club. We are really learning every day, so many new things, and especially we're coming all together now internationally with all the oncologists as well as surgeons to make our contribution for the country as well. And also we are contributing rest of the world as well by sharing our knowledge. So I really wish this Oncology Club will go further and make a difference for the treatment of breast cancer in our country. Thank you.
So I request Professor M.A. Hai sir to say the last word, so then we declare the award. Sir.
Okay, thank you all. It was a great occasion. I enjoyed the whole occasion. My special thanks to Dr. Peter Schmid again, and also to Dr. Farid, Arunangshu. Given good speech. My thanks to all the participants. We want to see you again next Sunday. Goodbye. Okay, Kamal, you can announce now the result is ready.
So thank you, sir. So now we want to declare the prize winner. So our today's prize winner is Dr. Sharif Ahmed. He is from United Hospital, Dr. Sharif Ahmed. Congratulations, Sharif.
Where is he?
Where is he? Sharif, can you show your face?
Yes, of course.
All right.
Thank you, everyone. Thank you, Kamal bhai. Hello, Chaki sir. How are you?
Thank you very much, Sharif. Congratulations. But I need to see your face for a second. COVID
This
will
is
not
for
end.
second time. This is for second time.
So he's
Just a minute.
developing a habit of getting the quiz.
Yeah, habit. He's developing a habit. So third time he will be disqualified for the next 5 sessions.
Okay, good recommendation. Okay, so now we want to finish our session here by giving thanks to all the foreign faculties, local faculties, participants, and to our academic partner. As Professor Peter said, that this is only a few good side of COVID is that we are getting connected in this era of social distancing, and we are trying to learn from each other. And definitely it was a great day to have somebody like Professor Peter Schmid with us. Last 2 hours was quite educational and enjoyable. Thanks to Professor Dr. Zakirullah for bringing him in, and also Dr. Farid to continuously supporting us. And our program was never successful without the active participation of our upcoming oncologists, whom I really appreciate. At that age, they are courageous to ask questions to people like Professor Peter, and when Peter was scratching his head to answer, that really I enjoyed. I'm really looking at it, and hopefully we will be enjoying in coming days, and hopefully in some other session we will meet Professor Peter again, and let us all